approach to brain anatomy. Okay, brain is such an important structure. The ways to approach brain on CT and MR. So basically, what I will be telling is how to recognize various structures and how to look into brain from the very start for those people who don't know anything about radiology. It's very basic actually. Brain is divided into cerebrum, diencephalon, brainstem, midbrain, pons, medulla, and cerebellum. So basically, supratentorial and infratentorial region. The tentorium is the region which divides the four lobes: frontal, temporal, parietal, and occipital, and divides all of these areas, cerebrum from the cerebellum. The infratentorial region, which contains the brainstem and cerebellum. There is a ventricular system going in between the two tentorial regions, and then we have diencephalon in between. What are the contents of diencephalon? This middle one is diencephalon. It is a complex structure containing many of the important regions where pathologies have devastating effects, and many different tumors are related just to diencephalon. And then brainstem has obviously midbrain, pons, medulla, and medulla oblongata is continuous with the spinal cord. Brainstem tumors are totally different category. Brainstem pathologies have very peculiar appearance, and they involve infantatory region at times. Epicenter is a must to tell. Okay, diencephalon, its complex one has thalamencephalon, which contains thalamus, corpora geniculata, epithalamus, hypothalamus, posterior part of the third ventricle. You don't need to remember all of these structures until unless you have a pathologist. Go to internet, look into it. But what you need to know that this complex structure has few pathologies which are related, and we need to identify them, uh, which area they are involving, especially when you have a scan and there is involvement. Go back. Two, three things which I would like to tell you. This is corpus callosum, that is thalamus, which you cannot omit thalamus and corpus callosum. Corpus callosum has anterior genu and the body is planium. There's a gland called pineal gland. Pineal gland has internal calcification in it, which are seen better on CT, and that's a normal thing. So the calcification part actually is a clue for many of the pathologies there. Then we have mammillary bodies. These anterior two small structures are mammillary body, posteriorly is the tactile plate. So these three, four structures you need to remember. Then pituitary gland, obviously, and then brainstem, fourth ventricle come down. Ventricular system, it's important part of the brain. Ventricle system has its own pathologies. We have two lateral ventricles, one third ventricle, which is a midline structure, in the fourth ventricle. Um, a report of any CT or MR brain is not complete until unless you don't comment on the ventricular system, especially hydrocephalus. When to call hydrocephalus and when not, I will tell you. Um, there are different connections. The ventricular system is a one system which interconnects all the ventricles, the lateral ventricle, third ventricle, fourth ventricle together. So there are few foramina or communication areas between these. Interventricular foramina, the name tells it's between the two ventricles. Interventricular foramen, there's a hole, its name is Monroe, and it connects lateral to the third ventricle. There is cerebral aqueduct of Sylvius, which connects third to the fourth, and a median aperture. Median M for median M is Magendie, lateral apertures L for lateral, for Lushka, and these connect the fourth ventricle to cisterna magna and CP angles. So what you need to remember are Formant of Monroe 1, aqueduct 2, and 2 median. One is Magendie, two lateral Lushka, right and left where they are. Let's see. This is axial T2 image. This is the foramen of Monroe, the two lateral ventricles in the midline slit like third ventricle. On sagittal, it looks like this on T1. This is foramen of Monroe. Why this is important? Because lateral ventricle has some pathologies within the substance of the lateral ventricle. Like its horns are named according to the lobe they are. Like this is frontal lobe, parietal lobe, occipital lobe, and below is temporal lobe. So this is anterior horn, this is lateral horn, this is occipital horn, and a temporal horn. So the lateral ventricles take the name of the lobe in which they are residing. The foramen of Monroe is important because that is a draining area. Pathology here will call ballooning or upstream hydrocephalus of this area. So any pathology lying here will be crucial. That will cause a non-communicating hydrocephalus, that it will not be communicating with the rest of the ventricular system down. So Monroe has a specific tumors associated. So that's lateral ventricle, then a foramen of Monroe communicating with the third ventricle. Now from third, the CSF will go down into the fourth ventricle. Here's the fourth ventricle. Now the communication between the third and the fourth is a duct. This linear area, it is called the aqueduct of Sylvius. Then the fourth ventricle, now the CSF has to go down from here into the spinal canal. So midline is foramen of Majandi, and towards left and right are the foramen of Lushka. Now, what about these? These are basal cisterns. These areas where we don't have any communication area, these are basal cisterns. Now, pathologies from here, anywhere causing mass effect on the ventricle system is called hydrocephalus. So hydrocephalus is not a diagnosis. It's a secondary or ancillary feature which is telling us something is going wrong. Whenever there is hydrocephalus, just see how the things are going and where the pathology can be. Okay, so lateral ventricle, as I told you, has anterior frontal horn, temporal inferior horn, body, trigonum, atrium, occipital posterior horn. So the body is mainly between the interconnection between these. Bilaterally well developed only in 20% of the subjects, and the occipital horn may be absent or poorly developed, asymmetrical. So when you see some asymmetry within the lateral ventricles, especially the occipital ones, don't call it a pathology. It can be a normal thing to happen. Okay, the cisterns, basal cisterns, which I was talking about, they are 3 cisterns and they have specific names. Sorry, prepontine, quadrigeminal, and we have another cistern here. So the quadrigeminal and the star-shaped cistern, this one, and a prepontine cistern. These 3 cisterns are, sorry, I need to admit people again and again. So this is a W-shape cistern, which is at the infratentorial, just at the level of tentorium, supra and infratentorial margin, which is W-shaped cistern. Then that's a star-shaped cistern, which is at the level of midbrain, and then at the level of pons. Anterior to the pons is a prepontine cistern. So it's a moon-shaped cistern and a diamond shape and a W shape. This is a quadrigeminal system because of 4 sides. Okay, basal cisterns. After reading about the basal cisterns, how to detect hydrocephalus is present or not. If you see temporal horns, these are the temporal lobes on both sides. If you see ventricles symmetrically are visible in the temporal horns, that is a sign that hydrocephalus is present. If you don't see temporal horns, normally they are not visible. If you see them, it's hydrocephalus. If you don't see, it's not. So the most reliable sign to say that hydrocephalus is there to see temporal horns dilated. Now, when to decide, get a CT or an MR, basically in what situation you should go for them. In trauma, that is the main indication, go for a CT, not for MR. MR is investigation choice for rest of these. Though in infection, tumor, demyelination, other disorders, CT can be a first modality of choice and can decide later on when to do an MR or not. But In infection and tumor, usually MR is the modality of choice to differentiate, because infection can mimic tumor and tumor can mimic infection. Pseudotumors and radiation necrosis, demyelination disorders, MR is the investigation of choice. In congenital, you may have to do CT, MR afterwards, and the CT can be helpful. And metabolic, usually MR will detect a signal change before any structural pathology. So MR would be an investigation of choice in most of the condition except trauma. Now, how to differentiate the different brain structures according to their density? In CT, we use the word density, the relative density, how dense the structure is going to define the recognition of pathology and a normal tissue. In MR, we know the signal change will tell us that the signal has reversed, so it's a pathological thing. On CT, the density will tell how. We have different numbers which are called Hounsfield units, or like a unit which tells how dense the structure is. So we what we do is we take water as zero density. So anything which is water density thing is we it will be a neutral one. Above that and below that are different. So how to differentiate between those? How we calculate the Hounsfield unit, and how they are going to help us in differentiating which structure has fat or which pathology has calcification and all. So if something has value in minus, that will be low dense, like it will be lighter, especially air is lighter, so it has value in minus 500, minus 1000. So if anything like lung is there, if there is any air present, free air or any confined air, it will be giving a Hounsfield unit of minus 50. If there are structures which are more dense, like bone, the density of bone is more than water. So water is less dense, that will go in plus things. So bone has density 500 to 1000. Soft tissue will be having a density a little bit more than water. Similarly, blood has a different one. How? Okay, we have different windows which will help us in detecting pathologies and differentiating different structures. Now, this is a normal bone window which we all see, and that's a bone window. Now, you can clearly see the difference between the two. Here, we can see the clear pathologies of the bone. These are two sutures, though no pathology is there. Um, and this is soft tissue window or brain window, which tells us more details about the brain tissue rather than the bones. Here, we can't tell anything about the bones. So, whenever we have to see the specific things in a brain CT, we have to change the windows according to the uh, nature of pathology we are looking for. Like if for bones, we have to go for bone window. Here, we will be having a Hounsfield unit of plus 500 to 1000. In water, like this is a black, this appears black, so it will be having a Hounsfield unit. CSF will be having a unit of 0. Now, if you see things which appear more whiter, will be having density more in plus plus plus. So air which appears more blacker as compared to this one even will be less dense, as it has value in minus. So scalp fat and air will be like more blacker than this. If you see this, this is water, and this black fat appears more blacker as compared to the background water thing, and air appears even more blacker as compared to this one. So that will be in minus values. The tissue, brain tissue, it appears whiter than this. Now, this is brain tissue, this is brain tissue, that's bone. So they all appear more white. So they have Hounsfield unit in plus values. Always remember there are three things which appear bright on brain CT. There are three B's. B for bright. It's bone, bullet, and blood. This is scan of a patient. These are serious slices. Here we can see three different windows. This is a normal brain window or soft tissue window. Here we can see the brain parenchyma. This window is like air window. We can see air more or soft tissue more clearly, and that's a bone window. Here we can see the bone more clearly. The detailed structures, the inner outer table and tubercular pattern as compared to both of these. Now, this patient had trauma. There's a bullet which hit the right frontal lobe, and there's a fracture over here. We can see a scalp hematoma that's bleeding actually, and in the frontal sinus as well. And there's a bleeding within the brain parenchyma as well. So, this is very clearly showing three white things, like that's bullet or a foreign body. This appears very, very bright on CT. Then we have the bone, which appears very, very bright on CT, and then we have blood. Now, there is density difference because though these three are, you know, white, and this is white. So if you compare, it's more whiter than the bone on the bone window. So these three white things will appear white only. Rest of all the things are gray, black, or different levels of gray on CT scan. The blood is less whiter as compared to the bone, and the bone is less whiter as compared to the foreign body or the bullet. Why? Because of the density difference, which was the numbering. So blood has low density as compared to the bone, so it will appear less whiter than this, and this has very, very high value, and this will appear a little bit, you know, more brighter as compared to the bone. um I'm skipping many of the things because it will go beyond the scope of this talk, how to approach more of it. Things which are practically important in brain CT while reading brain CT are more important. Things which I want to tell you guys is the base of skull foramina. Many people, they are afraid of knowing how to report that base of skull foramina are involved or not on imaging. There's a little bit of scheme. You need to know three or four things for that. What you need to do is go to the base of skull level, and the hallmark which I use is a clivus. Now these are the two area slices, axial slices of bone windows. You can see the bones more clearly. uh, Go to down slice and you can come above. This is a upper, a little bit more up, or you can just go up and move, scroll down. What I do is I prefer going from below to down, because this is clivus. It's a hallmark for me. I can just follow it up and can see the base of skull foramina. Now, just lateral to clivus, this small slit-like thing is a median canal from where the fifth nerve, trigeminal nerve branches, they do occur. If there is some pathology going over here, if you don't see this slit-like line, there's a little bit rotated film. There must be one on the other side as well. So if that is broken or gone, or a bone around it is disrupted, the fifth nerve is involved, the patient will present with the symptoms like that. So you have to look for this median canal thing. Then we have two different dots, this one, and this one. This linear one, this one, these are two carotid foramina. So the internal carotid artery passes through these. These are behind the clivus. So this one bigger one dot is internal carotid artery passes, so it's a carotid canal. Then behind this, the carotid thing is another phenomena. This one, this is jugular phenomena. From here, the internal jugular vein passes, and you see the jugular vein is a continuation of the sigmoid sinus here. So that sigmoid sinus, there's no foramina over here. The sigmoid sinus will drain into the internal jugular vein. So the three things we learned on base of skull image, from coming below downward, from at the level of clivus, we have three things: median canal, carotid canal, and jugular foramen. These three things should be intact. Now if we come a little bit above, we have these two structures again. Now you see this foramina is a little bit open, and if we go down that, then it will close a bit. So carotid canal and jugular foramina will remain. from the sigmoid sinus, the jugular vein is draining into it. And we have three or four different foramina. So if we start from anterior to posterior, posterior to anterior in a sequence, we have for orbital fissure. This is orbit eye. Behind the eye, we have this fissure. The sphenoid, behind the sphenoid bone is an orbital fissure. From here, the nerves are passing. I have just one. So when we move, we were at the slice above the clavis. So there is foramen rotunda, ovale, and spinosum. Spinosum is a smaller one, so just remember the name S for small, and that's the spinosum one. Oval shape is ovale, and foramen rotundum is there. So these maxillary artery and branches of fifth trigeminal nerve and internal ascending pharyngeal artery, the three respectively pass through these foramina. So they are in a row. Oval shape is ovale, smaller was spinosum, and the more medial one is foramen rotundum over here. So these foramina are important because um, involvement of these foramina by tumors, by destruction by fracture or anything is crucial, and patients do present with cranial nerve symptoms. Now, type of hemorrhages, there are four type of hemorrhages which can be detected on CT. So how to differentiate those ones? This is a little bit pathological slide. Basically, I wanted to tell you the difference between these because in CT, most of the most common indication of the CT in trauma setting, and other ones is to look for hemorrhage. When you see a hemorrhage like thing will be white on CT, how you are going to differentiate which fracture is there. Oh, sorry, which type of hemorrhage is there? You have to characterize that. Yeah, this is the type of hemorrhage. So it can be epidural, it can be subarachnoid, it can be subdural, or it can parenchymal. So the parenchymal is the most easier to define because it is within the brain. Parenchyma, subarachnoid, epidural, and subdural. These are the ones which are within the dura, related to meninges. Now, how they are related? Um, First of all, subarachnoid, they are within the arachnoid space. Now if you see there's this blue lining which is around all over in the brain, this is the dura mater. Okay, then we have this brain parenchyma, and something going in between these two is these dotted things which are the vessels. Okay, if something occurs below this blue line, it's epidural. So what happens is it is bounded by this thing, that here it stops, here it stops by the sutures. There is these lining is adherent to the suture lines here, here, somewhere over here. So this bleed will be stopped, and it will appear as convex shape, this and this. So this epidural space is totally out of the brain parenchyma and the meninges, and it will be inside the bone, outside the brain parenchyma. So this is usually related to a fracture. Whenever you see this, look for a fracture. Then we have subdural hemorrhage, which will be between um, the vessels of this brain and brain parenchyma, and it will be below this blue line, which is the dura mater. So sub mean below, dural is for dura, and subdural, below the dura, is a subdural hematoma, and it will be traveling. It is not bounded by suture, so it can travel all along in the brain. So parenchyma will be within the parenchyma, and subarachnoid hemorrhage, which will be closely applied to the brain parenchyma. Here we can't see this vessel thing which we could have seen in the subdural one. So one more thing which I would like to tell you here is the age of blood, which you have to see on CT and MR, because I told you the Hounsfield unit, or the density of any pathology or tissue, will tell you what are the contents and how dense it is. Suppose there is acute bleeding, it will appear very very bright, as I showed you before in one example. So that blood will be like going, active bleeding. It's going on and on and on. Whenever the blood bleeding settles, so there will be hemosiderin, there will be deposition of deoxyhemoglobin, stuff like that. That will become more denser. It will be like clotted blood. So the house will, the value will change. It will not be whiter anymore. It will become gray or darker. So that will tell you the age of blood as well. So you have to mention if you see a bleeding like that. Okay. Then we have two, three things which I want to tell you on brain MRI. Cranial nerves. This is very, very important. If you see, there are symptoms of cranial nerves and you miss pathologies which are related to cranial nerves, it's not a good thing. So, how to look into cranial nerves? How they are? What are the areas where you should look for? So the first thing is olfactory nerve, which is number one, and the optic nerve, which is the cranial nerve too. So just go at the level of orbits and a little bit above, you can see the basal area of the frontal lobe, this one, and you can see these two whitish, or a little bit more high signal areas, foci, anteriorly. These are the olfactory groove and olfactory bulb, which is the site of first cranial nerve, which is the olfactory nerve. Then optic nerve is obviously within the canal orbits, and here the two nerves join to form the optic chiasma. This is the area for second nerve. The third, fourth, sixth nerve, we have done first and second. Third, fourth, and sixth. Fifth is a one which goes, into different spaces and different areas. So the cranial nerve, the trigeminal nerve has one, two, three different veins which go along the brain parenchyma. Now, uh, that's the area in the CP angle. This is a mid. Pons area, and that's cerebellum. So the CP angle is the one where we do see abducens nerve and the fifth nerve, few areas, and that's a Meckel's cave where the nerves traverses, and schwannoma is very important part of this. Here we see the two carotid arteries and the cellular area, supracellular system where it is located. So that's the area where third, fourth, and sixth nerve are seen. I hope I have a picture for that. No, I guess I do not have. Okay. The third, fourth, and sixth, they are confined more at the base of skull region in around the carotid arteries, where basically they are related to the pituitary gland. That's a basilar artery, though. So third, fourth, and sixth complex will be looking more towards the side of the midline, and then the fifth one more at the CP angle. Seventh and eighth are very easy. They are like going along the ear. So that's internal ear cavity, and you can see these two lines as seventh and eighth nerve complex. And then 10th, 11, and 12, glossopharyngeal, vagus glossopharyngeal, and hypoglossal. So a little bit below, when you come down, we have this spinal cord start. The 11th accessory nerve will go along this glossopharyngeal, and uh, the vagus, they have course along these areas which are lateral to the cerebellum. One thing which is very very important, which always found very tricky during my reporting thing, was the um, neonatal brain. Uh, we are looking into adult brain again and again and again and again. It becomes like second habit to us. So what about the children? Children are not young adults. They have different kind of anatomical details and MR. So basically what happens is, when a child is born at a term age or preterm, there's no myelination. The myelin is white, and myelin is basically fat, so that appears white on T1 and white on T2. Now whenever there's demyelination, myelin is not present, so that thing will be uh, blacker. And whenever the myelination will occur, that thing will start appearing whiter. So you got my point. The fat is white. Whenever there's no fat or there is no myelin, there is black signal. Whenever there is myelin, the things will start appearing white. These images from A to G, they are of a baby. These are normal images on MR. What I want you to is look into this image, the first one at A, and then the last image, G. Now you see a marked difference. Look like these two different brains actually. These are not, these are normal images of just one patient. Now what happened is on at birth, we see something is white over here, and we see something white over here, and we think this is pathological. Then we see something white in the central area, then we see something more central but the peripheral is not there, then we see a little bit more below, rest of the brain is fine, then we see something more in the midbrain, then we see something white all over the brain, and the central structures have become darker as compared to which were white at the first instance. So what has happened over a period of 2 years or like 18 months or so, in neonatal brain where there was demyelination, there was no fat. This is fat, which is white. There was no fat, there was no myelin. This area was appearing blacker. Now, when the myelination process has completed, the white thing has there, the things have become whiter. So the white matter, which is the deeper inside, that there was no myelination. This one. So this was more blacker, and this, if you look very carefully, there was something more bright, more whiter as compared to the inner white matter. So the gray matter is more bright, and the white matter is black. Exactly opposite has occurred here. Now the white thing is inside and the outside is black. So the gray has become grayer and the white has become whiter because of the myelin, because fat is there now. So again, I've just put a one picture of this newborn versus 2 years. As a newborn one's 2 years, the signal is totally opposite. See, that's black, that's white. So just remember, white is white, white matter is white, and gray matter is gray on normal images, T1, and in adults, and the reverse is true for neonates till the age of 18 months or so before. So don't call it pathological. Uh, do we need to remember these changes over the period of months and all? Yes, we do at times, because the central areas which I've shown you are more whiter. Uh, they may occur, as a pathological thing at times, but the age of the baby is more important when you're reporting a neonatal scan. How this location varies, that is important. You don't need to remember it actually, this whole thing, but important thing is that you should remember that as the age grows at 2 to 4 months, central semiovale, uh, that's the portion of central semiovale that becomes myelinated, then occipital white matter from posterior one, and then mid frontal, and then anterior frontal. So the occipital, the posterior aspect of the brain, this one is the first one to be myelinated. That will appear more whiter as compared to the rest of the brain, then more this area, and then anteriorly. So this area is the last one to become whiter. If it is blacker, don't worry, look into age of the baby and then decide. So at 3 to 5 months it's deep, and T1 on 4 to 7 months is subcortical one. Similarly, at 7 to 11, if you see 4 to 7, 7 to 11, then frontal, and 10 to 15 months or above, anterior frontal horn white matter at the subcortical region will be myelinated, and it will appear whiter. The first thing when you are looking at a brain, anything, like if someone asks you a question, what is the first thing you have to look into brain to look for a pathology? The answer should be, I will be looking for two things, not one. One is gray might white matter differentiation, which I just told you. See, if it's the way I'm telling you is a sequence of events coming. The gray and white matter, I just told you this white and gray thing difference. That is great and white matter differentiation, which you are looking on this D2 and flare image. You see the things are blacker on the flare. That's fine. It's a normal thing. We can see basal ganglia. We can see internal capsule. So there is something inside, and that's outside the sulcal and gyral thing, right? The first thing you need to look for is gray and white matter differentiation. You will be able to differentiate, yes, this is something in and that is something out of one. Now what happens is the first pathology, if there is something going on in the brain, the gray and white matter differentiation will be lost. You cannot differentiate. Just look at this. Here you cannot see something blacker as compared to this one. This outer thing and this inner thing, you can differentiate. There is something, but here with the pathology is you cannot tell exactly. There's no sharp demarcation. Something is gray and something is uh, white. So this is loss of gray and white matter differentiation. The second thing which will go first if there's a pathology is sulcal gyral pattern. Now you see these are the sulci and there are dips in between. This dip, this dip, this dip, this dip, and these are dips are sulci and gyri. So whenever there is loss of this thing, which is shown over here, you cannot see any sulcal and gyral pattern. That is called sulcal effacement, or means the sulci, these spaces they have, meet together. So that is, and the second thing which should come to your mind whenever there is a pathology. So I'm sorry, look into the sulcal gyral pattern and gray white matter differentiation. This is another example on CT. If you see, we have these sulci and these gyri. These sulci, these have CSF within the brain. Now, if you see, this is very symmetrical on this side as well. Now look into this. We have very preserved spaces over here. What happened over here? There is loss of sulcal gyral pattern, or sulci, they are effaced together. So that indicates something is wrong on this side. A little bit about the um, vascular areas in the brain which you should look for. That's dural venous sinuses. The venous system is, very complex, and we need to remember only 2 3 things which are sinuses. The superior sagittal sinus, that is along the midline area, inner, and then inferior sagittal sinus. These walk along the tentorium, the lining which divides the superior and inferior part of the brain. And then there's a vein of Galen, internal cerebral veins, and then straight sinus. Straight is for its location, it's straight, superior sagittal, inferior sagittal vein of Galen. And then we have 2 transverse sinuses. The name tells us these are transverse in location, and then we have sigmoid sinuses below, which drain into internal jugular vein. So we need to look into different sinuses. At times they mimic, thrombus versus arachnoid granulation. I will go into the details when we will read about the pathologies of this system. But 2 3 things you need to remember is look into dural venous sinuses, even in a non-contrast CT. The report again is incomplete if you don't see dural venous sinuses. MR venogram is a better modality of choice because it gives you time of flight images. You can see just white thing, all are venous sinuses. This is a superior sagittal sinus, inferior sagittal sinus, vein of Gala. You can see even cortical veins which are, supplying, draining the brain areas. Then this is confluence of sinuses. Here this superior sagittal sinus and the straight sinus meet at here, and then transverse sinuses go all the way to sigmoid and internal jugular vein. Whenever there is a thrombus, we can easily detect the venogram because there will be like a filling defect, something black inside any of these areas. One thing I would like to mention is always see dural venous sinuses on sagittal plane for this, and straight sinus, and coronal plane for the transverse sinuses. Otherwise, it's easy to miss dural venous sinus thrombus. Uh, Regarding the arterial anatomy, circle of Willis is like the most um, asked thing. The circle of Willis is, patent or not. So how is it formed? Basically, the posterior circulation is by the basilar artery. This is the basilar artery, which is in the midline. It's formed in front of the pons that divides into two posterior cerebral arteries. Posterior for like going posteriorly into the brain. Then internal carotid artery comes from down and divides into anterior cerebral and middle cerebral. So the anterior, middle, and posterior. So these three arteries are the main suppliers to the brain. Anteriorly means it's going anterior, middle is like going laterally into the mid part, the posterior ones going posteriorly. There will be a separate detailed lecture for all how to trace them, how to look into the pathologies, how to go for proper algorithm for CT angiogram of the brain. Just to give you example with circle of Willis is now how it is circle. There are communicating branches from here till here, from here till here, and above between these two. So there will be a circle-like thing when there will be small communicating branches. That is called the circle of Willis. Now, a little bit of quiz cases just for people. I will hurriedly go through these because lack of time constraints. This is a brain CT. Anyone would like to add, comment? Is there any pathology for this? I'm giving you like 15 seconds. I'm looking. Anyone would like to add anything abnormal you see? Yeah, very good. It's aneurysm of middle cerebral artery. So that's the one. Here it is. Uh, that's I just put this picture because you shouldn't look into the brain like as on the structures only, the extraaxial structures like pineal gland, pituitary gland, vessels. Vessels remain, an area of review area, as every radiological examination has a review area. So the vessels are a review area for you know the brain. Okay, this case I have just put to show three things. One thing is a practical point that look into a midline shift. One thing I told you before, look into circle gyral pattern loss of gray white matter differentiation. Third thing you need to look for is a midline shift. Midline shift means is the brain structure are centralized on right and left side both. This is a hematoma which is causing mass effect and causing midline shift. So see all the structures on this side, they're shifted and causing pressure effect towards the opposite side of the brain. This is a subdural hematoma. Um, and there is something very interesting. That is, this is a black thing and this is a white thing. Now, the density difference, which I told you before, comes role into play. This is something whiter and this is something blacker. That means this is more dense or this is acute blood, and that's less dense or blacker one, and this is an old blood. What happened has here is that this hematoma was there before and there is acute hemorrhage or recent onset hemorrhage has occurred within the hematoma. So it's acute on chronic hemorrhage. Patients usually which are anemic, they don't have good hemoglobin. The hemoglobin when drops down, there will be no acute blood density over here. So their whole hematoma, if even that is acute, will be a blacker. So many things you have to look into history while reporting such things. And then this is subdural. It is causing sulcal effacement. You can't see the sulcal jalid pattern. And there is midline shift. This is an emergency. Whenever there's a midline shift, it's always an emergency. Do call the physician. Okay. Another case I just put. Let me summarize it like carefully, quickly, because this has something which is interesting. Whenever you're looking at brain and other review areas, this cavernous sinus area and these lacrimal glands. This patient has lymphoma, actually lymphoma of the lacrimal gland, involving lacrimal glands. In my next lecture is on orbits and paranasal sinuses. I've presented on Sunday. If you guys want, I can repeat it. um, I'm going systematically from brain to neck spaces and then face structures, and then I will move to a little bit down. So this patient has lymphoma of the lacrimal, involving the lacrimal glands and some soft tissue thickening over here. That is a perineural spread of lymphoma, which is a known entity, but rare. Patient does present with cranial nerve symptoms in this and orbital symptoms, weekend related things. Okay, this is the last slide for this talk. And sample report checklist. Whenever you are reporting a brain thing or looking into a brain, you should have a checklist in your mind. This is a brain one actually. So MR brain report. You can just make a CT for it, out of it, in your own way, like brain parenchyma you have to look for, which gives normal signal intensities. You can just write densities throughout. So if it is MR, it's intensities. Otherwise CT has densities. So look into the normal signal densities. Always compare the right and left thing. And obviously great white matter differentiation, midline shift and stuff, ventricular system and basal systems, whether they're patent or not, there is some hydrocephalus thing which I told you. Temporal horn is the one to look for it. Intracranial hemorrhage, that will appear white. Infarct will appear blacker. Midline shift and emergency herniation. Herniation is again a separate topic. No focal space occupying lesion, whether there's a lesion or not for you. Corpus callosum, I told you. Diencephalon thing. Brainstem, cerebellum. Then CP angles. CP angles are the one where the pontine and cerebellum they meet. Seventh, eighth nerve complex area. Dural venous sinuses, very very important. If that's MR, it will be signal flow void. If CTs, you can just simple write their patent. Cella, that is pituitary gland. Orbital morphology, optic nerves. The last case I showed you, you have to look into the orbits. Paranasal sinuses and mastoids, which I haven't covered a bit. I will repeat them. Paranasal sinuses and mastoids should be looked for. And lastly, bones, marrow signal or bony abnormality on CT. So this is a checklist. Until unless you don't go through all of these, your CT or MR brain report is not done. You have to tick mark all of these. So structured reporting thing you can go through, you can use this sample as well. In all my talks I will be sharing things like for paranasal sciences, I will be sharing a sample report of it for temporal ears and all that stuff. Next spaces I didn't share because they are total different entities, so everyone has a different pathology related to it. So that's a little bit overview of you know um, about how to approach CT brain. These are the practical tips, not the basic ones. So these practical tips, when you keep them in mind, you will be able to look into those areas of the brain which are crucial, and you can approach them simply. When we read about neuroradiology properly, like different diseases, tumor is a separate talk, metabolic disease is a separate one, and other stuff, I will be telling you how to approach each and every one differently.